I don't like this term CKDu much, which lumps all CKDs of unknown etiology into the same basket. And I would like to use this term chronic interstitial nephritis of agricultural communities, or what we shorten as CINAC. Before you think I'm going to show you the cause of CKDu, I'd like to start with a spoiler. We still have not found a cause, not yet anyway, but I would like to share with you some thoughts on etiology based on our recent observations. Now, these are the areas in the world where there seems to be substantial numbers of endemic CKD of unknown cause. And out of these, only Mesoamerica, Sri Lanka, and Andhra Pradesh have biopsy-proven endemic tubular interstitial nephritis. Please note that they emerged almost simultaneously in the late 20th century from several areas in the world, in similar communities with similar socioeconomic status, and the topography in these areas was very similar: flat terrains, not high above sea levels, and similar climatic conditions and similar clinical, biochemical, and pathological features. And all are chronic tubular interstitial nephropathies. So the question is it the same etiology? Because I feel you cannot explain these epidemics without a same or similar etiology. Now, more than 30 etiological factors have been proposed, and these are some of them. Some of them have been proposed as the main driving force, and the others as contributing factors in the background. For example, genetics, herbal medicines, NSAIDs, snake bites, they are unlikely to be the main causes. So on our current evidence, is it heat stress or an environmental toxin which is the primary or necessary drive in CINAC? I'm sure both are involved, both are contributory, but what is the likely main drive? When you visit Mesoamerican countries and United States, you hear mainly about heat stress as the main cause of CINAC. So much so that some call it global warming nephropathy. The gist of this heat stress dehydration theory is that working in high temperatures causes severe dehydration, giving rise to recurrent acute kidney injury, which leads to CKD. To summarize the evidence, CKD was seen in workers who do strenuous work in the sugarcane fields and small numbers seen in other professions, but these workers also live in or at the vicinity of rural agricultural communities. And almost all studies on the workers in the field show mild pre-renal decline of renal function due to dehydration across a work shift. And some studies showed decline across the whole harvest period, and some go on to develop CKD. And now this Water, Rest and Shade program, which instituted hydration and rest for workers, diminished the decline of eGFR cross-shift and across the harvest. And of course, from the days in medical school, we have learned that dehydration does cause pre-renal dysfunction. So what all these studies have actually shown has confirmed what we knew for a long time. Now, we have previously published a comprehensive rebuttal of this theory as the main drive. We have argued that heat stress and dehydration is most likely a contributing cause, but is highly unlikely to be the main driving cause of the disease. I think any CKD would get worse with recurrent dehydration and heat stress. It's an escalating force. We have pointed out that the degree of rise of global temperature from 1960 to 1980, about 0.6 to 0.8 degrees of centigrade, is unlikely to have caused a major change to kidney health. Also, there are many more hot agricultural areas without CINAC and those with CINAC. There are many other hot jobs like working in steel foundries and glass factories and oil and gas well sites. They are not associated with this kidney disease. And there's this strange mosaic-like distribution of CINAC. Adjacent villages to CINAC prevalent villages sometimes do not have it, and they are exposed to the same heat stress. And this is against this theory as well. And of course, in Sri Lanka, the three-wheeler tractor has replaced much of the manual work by farmers over the past 3 decades, and they are not exposed to heat stress as much as Mesoamerican sugarcane plantation workers. Now, there is currently little doubt that even mild in-hospital AKI events with full recovery might lead to the development of CKD. As this graph shows, hospitalized people who have AKI have a much higher probability of end-stage renal disease after discharge when followed up for 2 years. And people who get AKI on CKD progress faster to end-stage renal disease than those with CKD and no AKI. This pathophysiology of such an AKI-CKD continuum has been discussed comprehensively, and I would not go into that here. But it's crucial to recognize that most published follow-up studies of AKI, which have revealed CKD as a long-term sequel, are retrospective from databases of hospitalized AKI patients who mostly have been elderly with multiple comorbidities such as diabetes, hypertension, CKD, heart disease, etc., and many in an intensive care unit setting with sepsis a common accompaniment. And workers in Central America and Sri Lanka have been previously healthy, younger individuals with no other comorbidities who possibly develop community-acquired, recurrent, acute pre-renal dysfunction at what I would call a pre-Akin stage 1 caused by dehydration, because the acute kidney injury that they have demonstrated is often less than 0.3 milligrams per deciliter. And none of the follow-up studies on AKIs equally have included pre-Akin stage 1 patients in their long-term follow-up. These hospitalized patients, probably they are included in the no AKI category. And there's no evidence these mild episodes of AKI leads to CKD. Then there's this question of children in endemic areas having early kidney damage. Multiple studies have shown evidence of early kidney damage in children in endemic areas. So I counted 22 studies, in fact, from various places. And these studies suggest that the pathophysiological process leading to SYNAC may begin prior to early adulthood. Now, we have studied children in endemic areas in Sri Lanka and found early kidney damage in these areas using urinary biomarkers such as KIM1 and GAL and cystatin C. These are the published reports in environmental research, in Nature Scientific Reports and World Journal of Pediatrics. As I mentioned before, early kidney injury in adolescents have been also demonstrated in similar studies elsewhere, and this is another piece of evidence which supports the toxic etiology of SYNAC. Now, we recently published results of this study in collaboration with Duke University in USA on heat exposure in school children in the dry climatic zones of Sri Lanka using biomarkers KIM1 and albumin-creatinine ratio. And we studied children less than 16 years with high heat exposure in 2 groups of each in endemic and non-endemic regions, comparing with a similar group of children with low heat exposure in each of these regions. Urinary KIM and albumin-creatinine ratio in participants with high heat exposure did not differ significantly from those in the low heat exposure groups in the 4 study zones. Now, irrespective of heat exposure, increased KIM1 excretion was observed in participants of CKDu endemic regions compared to those in non-endemic areas. So in this study, there was no evidence of an association of heat exposure with kidney injury in dry zone school students in Sri Lanka. Now, there was another recent published paper on heat exposure in Sri Lanka from the group from University of Ruhuna, which suggested that heat exposure alone may not explain the epidemic of SYNAC. Now, they compared 5 occupational groups from 5 climatic zones. Fisher folk working in the driest and hottest region in the country called Mannar have a lower prevalence of CKD than farmers in the endemic dry zone of Ua province. And these fisher folk actually work for longer hours in extreme heat than the farmers. And the prevalence of CKD was not significantly different between the fisher folk in Mannar and the tea plantation workers in the colder, wet zone area called Walapane, which indicates that heat stress may not be the main drive cause in SYNAC. I would like to thank my collaborators, Professor Mangala de Silva of Ruhuna University, Professor Nishantha Nanayakkara from Duke University, USA, and Dr. Samira Gunasekara from University of Ruhuna. They have been the main drives behind these studies. Now let's look at evidence of a toxic nephropathy from pathology. In 2020, an international consortium of researchers led by Professor Mark de Broo of University of Antwerp in Belgium reported a distinctive constellation of lesions in the proximal tubules of 34 SYNAC patients. Now, modified Jones staining of renal biopsy specimens from endemic agricultural areas in Sri Lanka, El Salvador, and India revealed silver-positive granules in the cytoplasm of cortical proximal tubular cells under light microscopy and electron microscopy. And these granular inclusions were seen inside dysmorphic bodies, and they were very dysmorphic and only seen in proximal tubular cells and not much in distal tubular cells. Transmission electron microscopic pictures show these are better. And you can see the affected proximal tubules and the unaffected distal tubules, which is in the lower right-hand corner. And these sections were also stained with a marker for cell proliferation called proliferating cell nuclear antigen, or PCNA. You can see that the affected proximal tubular cells show minimal proliferation and no apoptosis. And this suggests that the proximal tubular cells are in a senescent stage. In short, they are dying. In comparison, if you look at the distal tubular cells, proliferation is very prominent with apoptotic cells, suggesting that there is distal compensation for the proximal tubular functional deficiency. This phenotype of the senescent proximal tubular cells and hyperfunctioning distal tubular cells is highly suggestive of a toxic nephropathy. And in animal models of heat stress, the main damage was to the distal tubules and outer medulla. Now, these abnormal lysosomes were seen in SYNAC patients from all areas we studied, but they were also seen in patients who were on CA9 inhibitors, lithium, lomustine, and those with light chain nephropathy. So these lesions are not specific for SYNAC, but it could be a useful diagnostic aid taken together with the clinical diagnostic criteria, and it certainly motivates and opens up new avenues into research and on etiology. Now, similar lysosomal inclusions were found in SYNAC patients in another recent study, a collaborative effort between the Candy group and a German group of 13 patients with SYNAC. Prof. Daniel will probably speak more about this in his presentation, but they have seen similar lesions in 19% of other non-SYNAC kidney diseases, including 6 out of 35 IgA nephropathy patients and 4 out of 6 hypertensive nephropathies. So the diagnostic utility of these lesions for SYNAC is now contentious. I don't know if this is because the patients in this study had early SYNAC with probable acute kidney injury because they recovered renal function over the next 2 years, or if it's a difference in staining techniques or simply observe variance between pathologists. But my topic is not diagnosis of SYNAC, but etiology. So what is more important, which supports this argument of a toxic hypothesis, that they found these lysosomes about 3 times commoner in SYNAC patients compared to controls. And they also suggested that mitochondrial swelling, cell detachment, and increased vacuolization, all of which we also described in our paper, presents a spectrum of a disease that a nephrotoxin may have induced. Now, this research paper, which appeared in the American Journal of Physiology this year, I feel is an important addition to SYNAC literature, and this is a comprehensive study of urinary proteomics in SYNAC patients. They identified 636 proteins of renal origin in urine of CKDu patients, and changes in the urinary proteomics suggest dysregulation of lysosomal and mitochondrial function in SYNAC, That is, they detected decreased amounts in urine of megalin and kibulin, which are proximal tubular reabsorption proteins, pointing to a mitochondrial dysfunction, and all proteins related to the KEG lysosomal pathway were reduced, indicating a lysosomal dysfunction. And this fits in well with the pathology findings of the last mentioned two pathological studies, indicating lysosomal and mitochondrial abnormalities in SYNAC patients. And furthermore, compared to other CKDs, there was a markedly reduced aquaporins and heat shock proteins in urine, which again speaks against dehydration and heat stress as a primary cause. And there's this interesting paper from the same group. They conducted chemical analysis of drinking water in endemic regions of Sri Lanka and exposed the water to zebrafish to examine the kidney developmental effects of this exposure. And they found that the drinking water is contaminated with various nephrotoxic compounds, including agrochemicals as well as heavy metals, but at levels considered safe for drinking. Remember that levels given as safe levels are for acute toxicity, and we do not know the levels which cause harm in the long term, low-level exposure. An exposure to drinking water impeded kidney development in zebrafish and caused mitochondrial toxicity and altered mitochondrial function. And studies have shown that damaged mitochondria and mitochondrial dysfunction as a key factor underlying CKD. And this is a recent study from Baylor School of Medicine from David Sheikh Hamad and his group. They compared 52 migrant workers with men and 63 patients with other CKDs. And Mesoamerican nephropathy they found was significantly associated with exposure to paraquat and agrochemicals. In an extension of the same study, they exposed mice to recurrent sublethal doses of paraquat and demonstrated that they get chronic interstitial nephritis, very similar to Mesoamerican nephropathy. And they examined the tubular expression of these channels called OCT2 and MATE1 in mice, which studies support previous exposure to paraquat. And they found very similar changes in OCT2 and MATE1 channels in 11 biopsies of Mesoamerican nephropathy. And what is interesting is that kidney injury was less severe in female mice, and the channel expression also was less prominent in female mice, which was also reflected in human kidney biopsies, which could explain the susceptibility of males to men to Mesoamerican nephropathy, which of course is also seen in SYNAC in Sri Lanka. But the possible good news is this paper published this year, decreasing incidence of hospital-diagnosed CKDu in North Central Province. Is it related to provision of drinking water reverse osmosis plants? And they said that the incidence of hospital-diagnosed CKDu in affected North Central Province of Sri Lanka is decreasing, possibly due to provision of safe drinking water. But you'll have to also remember that there was a ban on certain nephrotoxic agrochemicals like paraquat and diazinon in 2014. I wonder whether this also could have contributed. These are the main toxins implicated in causation of SYNAC. We have to investigate each one of these: agrochemicals, heavy metals, fluorides, hardness of water, and silica. And I would like to leave you with some food for thought regarding historical episodes of CKD epidemics, like Itai disease, Queensland nephropathy, Balkan nephropathy, Tunisian nephropathy, then Chinese Serbs nephropathy, and analgesic nephropathy. Now, all these were chronic interstitial nephropathies, and all turn out to be toxic nephropathies and turn out to have a single toxic cause. And in every instance, except with Chinese Serbs nephropathy, where the cause was obvious, it took more than 50 years to discover the offending toxin. So we have about 25 years more to discover this. But there's a saying that the cleverest criminal is the one who has not been caught. Is there a substance X which we have not even thought of? So, ladies and gentlemen, these are some photographs of the north central province of Sri Lanka, the cradle of the 2,500-year-old Sri Lankan civilization, which unfortunately has also been the cradle of this devastating chronic kidney disease. Thank you very much.
Topic given to me is etiopathogenesis of CKDu. What have we learned from epidemiological studies? So when I saw this topic, so I had a question. So should we struggle on this? Because sometimes without our notice, this disease can disappear. So have we to work out? But then I again looked at the story. It is a chronic interstitial nephropathy. And at least there were 3 major epidemics: Bolkan nephropathy, Itai disease, and lead nephropathy in Australia. And these cases of sporadic interstitial nephritis, it is a universal phenomenon. You see those cases everywhere in the world. And current epidemic is going on more than for 20 years now. And it is sort of almost limited to tropical and subtropical countries. And in Sri Lanka, so it is mainly in the dry zone, but not evenly distributed throughout the dry zone, but found as hotspots in the dry zone. So disease, the prevalence is around 10 to 20% according to the different investigators. And you have to do screening as the disease is silent or asymptomatic. And out of this, if you take 10 people who are screening positive, at least 9 you can't offer biopsies. Their kidneys are small and shrunken. And so in the biopsiable patients, as well as there are some sporadic cases, those who present with vague symptoms like fever, myalgia, general ill health, those patients we can do biopsies. The findings are of chronic interstitial nephritis. But as per Christoph, it is a wide range. Usually in the established disease, you see only chronic changes dominated by tubular interstitial fibrosis, tubular atrophy, and glomerular sclerosis. But there are in-between cases, so they are having both chronic and acute changes. And also, you see florid inflammation in these people. This is a more enlarged picture. So there you see interstitial infiltration as well as tubulitis as features. So who is actually at risk? As I told earlier, they are living in the dry zone of the country, but they have to live in the endemic area. Even in these endemic areas, it is not evenly distributed. It takes sort of mosaic pattern of distribution. And there may be a familial clustering, so either microenvironmental exposures or genetics are going to be important. And you don't diagnose established CKDu commonly in children, but you diagnose them after the age of 40. So whether they need some sort of conditioning before developing the disease. And majority living in these areas, they don't have the disease. Only 10 to 20% of the people develop the disease. So actually, who is at risk? Yes, we know that tropical and subtropical environment is a risk factor, and it is more common in hotspots and it takes mosaic pattern distribution. And most of the people living in these areas are doing hard-working population. And children seems to be not having established disease. So either the adult behavior or else there may be some epigenetic modification which predispose the patients to acquire the toxicity. And something seems to be playing a decisive role. It could be very unique exposure, or else it could be even genetic susceptibility. So people with having vulnerable genes only developing the disease. So we try to illustrate our hypothesis. So if you are having the vulnerable gene, but if you don't expose to this whatever the risk environment, you will not develop the disease. But if you expose to this vulnerable environment, if you don't have the gene, again, you don't develop the disease. But if you are having the gene, and after years of epigenetic modification, you acquire the kidney injury, and afterwards also, they can be dormant for a longer time and later present as CKDu, because we all know the creatinine is a late marker of kidney failure, and it takes at least 40 to 50% of damage to get the fall in GFR. So this is a hypothesis we have put forward. So people with vulnerable genes, after epigenetic modification, they get the kidney injury and they sort of live another period with the subclinical disease. Later, they present as, they will be identified as CKDu through screening or they incidentally. But the question is, what is the injurious agent? So it is very complicated. When Dr. Chula Herath told there are more than 30 suspects. So what can you do if you suspect something causing the disease? You can do an experiment. So I think several investigators tried that, but again the results are inconclusive, because if you give whatever the suspected elements either to rats or zebrafish, they develop the kidney injury. But we don't know whether it is the lesion or else they are different lesions. And again, most of these substances can cause kidney injury in higher doses, especially the endemic area water itself was toxic. But we don't know that toxicity is similar to what we see in humans. So what next to do? Omics approaches are high throughput technologies that analyze biological molecules to understand diseases. This information can be used to discover biomarkers of the diseases and understanding the biological pathways that differ between the disease and healthy groups. So this is a good weapon to investigate the disease and to identify the pathophysiological pathways. So, but again, you have to have a model. So, how this disease happens. So, this is the model we are having. So, somehow this toxin has to enter the body either through inhalation or ingestion, and then there may be transporters. So, they will take the whatever the toxin, and the body will try to neutralize this toxin. So, if body defense mechanisms are effective or the detoxification mechanism is effective, some people may be neutralizing this toxin. And then whatever this injurious agent, it comes to the kidney and there will be markers of kidney injury. And as you all know, the kidney disease progression occurs with the inflammation, oxidative stress, and the fibrosis. And with the progression of the disease, you will see again different markers can appear. So representing all these the processes, the markers can appear in the our body fluids. And also we have to take into consideration the unhealthy exposures in these endemic areas, because we are seeing the various reports from different investigators regarding the unhealthy exposures in this area. So we have to take all these things into consideration when we are sort of applying this omics model into CKDu. Yeah, I will start with genetic susceptibility. So when we are considering the genetic susceptibility, we are having a few questions. Is there a genetic susceptibility? Is it single gene? It is going to be easy, but if it is multiple, it is going to be very complicated. So where is the variant protein? Is it related to detoxification mechanism? Is it a failure of absorption? Is it some abnormal protein or an abnormal transporter protein or receptor in the kidney itself? And again, there are various technologies to investigate the genes, and study design participants are going to be very important. So why we are thinking of genetic susceptibility? So at the individual levels, definitely within families, the disease occurrence is higher. But in some families, you see that the previous generation is having the disease, but in some families, only this generation is having the disease. So we looked at genetic or a familial tendency in one of our cohort. There were around 300 patients. Out of that, 60% of the people had family history of CKD. And around 30% had more than one family member affected with CKD. And there's no sort of much difference between maternal or the paternal transmission. It is around 10% for both. Then we sort of search for evidence for genetics and the kidney. So there are many studies supporting genetic relationship with the kidneys, and the new knowledge is sort of coming every day. Like there are more than 12 genes identified directly related to CKD, and there are reports showing association between CKDu and the genes. And in renal disease general, again, there are sort of very supportive evidence, and more than 14 genes have been described in related to toxicological pathways, and there are sort of abnormalities of tubular transporters which can lead to CKDu. So this study was conducted maybe 10 or 12 years back using GWAS technology, and GWAS compares the DNA of many people to identify genetic markers of diseases. Here, so they had a study design. So they identified CKDu, the biopsy proven around 300 people, and they invited controls from the endemic area. So according to their finding, 4 candidate genes have been identified, and out of these 4, this SLC13A3, which is a sodium transporter, seems to be very important. But yeah, the population attributable risk for this SLC13A3 was 50%, and it indicates at least 50% of the people who don't have the gene develop the disease. And one disadvantage was in this study was controls were younger than the patients. So whether they have developed CKDu after recruiting after the study. Epigenetic changes, again, so these changes occur after the after your birth? And are they going to have any association? So this is one study, sort of look at the microRNA. So there were sort of 10 dysregulated microRNAs among CKDu and the endemic population, and 3 identified microRNAs are related to fatty acid metabolism and synthesis, and impaired fatty acid oxidation pathways augment the risk of renal interstitial fibrosis. So can this be a epigenetic trend? And we have to identify the injury. So it helps after sort of reporting this acute kidney injury in this Mesoamerica as well as Sri Lanka. So, but mostly they are non-specific, the biochemical and the other parameters. They come with vague symptoms, but the biopsy is sort of, as I showed earlier, they are having acute changes more than the chronic changes. So next, can we use the biomarkers? So this particular study, we have used 26 renal related biomarkers, and we selected some for further studies. And these eight urinary markers we evaluated in CKDu against control. So out of them, several seems to be important, and all represent tubular damage. And interestingly, retinol binding protein 4 was low, and the osteopontin is high in CKDu. But the serum, you had a higher retinol binding protein. As we know, this retinol binding protein is a transporter, and it is reabsorbed through megalin-cubilin system in the kidney. So, and other than vitamin A, there were reports describing or reporting that retinol binding protein transports other proteins as well. And to study the inflammation and the fibrosis, we used TGF-beta1. It is a key driver of fibrosis organs such as lungs, kidneys, and heart. According to our results, the levels were high in CKDu and mostly in less symptomatic late disease group. And another technology we can use is proteomics. The proteomics is study structures, functions, interactions, and dynamic modifications to understand cellular processes and disease mechanisms comprehensively. So, Dr. Chula Herath, he sort of told some findings in these studies, and according to their findings, there were some proteins expressed higher in CKDu and some were lower. And results indicate potential mitochondrial dysfunction and lysosomal dysfunction. And megalin and cubilin were lower in CKDu. Significant changes in the complement and coagulation system related proteins were reported. So we keep on generating very interesting data. Now the question is sort of how to correlate it to the disease as well as how to approach the etiology through this finding. So we had this question maybe 3-4 years back, and we sat together and looked at how to sort of correlate this finding. So these were the recommendations from ISN subcommittee. So the recommendation, first one was pursue longitudinal studies and make provisions for biorepositories. Bolster capacity for kidney biopsies, diagnosis, investigations of pathogenesis. Create an open access database of ongoing studies to enhance collaboration and transparency. Partner with participants and community leaders in study design and ensure return of study results to participants. So there have to be a very good collaboration between the groups. Build long-term relationships between international and local researchers that emphasize fairness, trust, and shared commitment. Thank you.